Hi, David. We're live.
Great. Good afternoon, everyone, and welcome to this virtual meeting of the Massachusetts Health Policy Commission's Advisory Council. Welcome to everyone on the public who is viewing this via the YouTube. Thank you for continuing to stay engaged and connected to the work of the HPC. And more importantly, thank you to all of the Advisory Council members who have joined this Zoom room today. It's so great to see all of your faces in my Brady Bunch view of my screen. So really pleased to have all of you here with us today. And really just want to start by a note of just gratitude to this Advisory Council. Even though we only met twice virtually this year, I think we at the HPC really relied on this council more than even in past years, and just want to thank you so much for your generosity in time and input, especially with regard to our health equity agenda, our virtual cost trends hearings, and of course the ongoing work in trying to understand the impact of COVID-19 on the healthcare system. I also want to thank all of you, not only for your work on the Advisory Council, of course, but for the work that you do within your own organizations over the past 10 months. This is just such an esteemed group of individuals. And if we move to the next slide, I think we can have the list of the names of everyone who's on the Advisory Council, and just really reflects a complete cross-section of our healthcare system and ecosystem here in Massachusetts that's been deeply impacted and working so diligently every day to battle this horrible pandemic and to save lives. Just looking through all of these organizations, from representing home care and our skilled nursing facilities, to our hospitals and our physicians, our behavioral healthcare workers, our community organizations, our advocates for so many different populations, our innovators who are working to develop a vaccine, and just incredible leadership represented here. So thank you for all of the work that you and your organizations do. In that interest, I will try to pledge to keep this meeting a little bit shorter than our hour and a half, and let people go a little early, recognizing that there is just a tremendous amount of work still to be done, and today and in the next few months. I also, before we dive into the agenda, speaking of that, want to make a public statement of support for all the frontline workers who are such a huge part of our response here in Massachusetts, and are tired and are burnt out and are in the middle of a second surge here, and will be going through a really tough period, I think, for the next 2 months. But your service is just so greatly appreciated. And I think I'm always struck by I have been struck by the real strength and resiliency of our healthcare ecosystem in Massachusetts, even through the significant challenge. And even though, unfortunately, this pandemic has exposed, I should say, further exposed many failings and weaknesses in our healthcare system, that will be our collective work moving forward about how to address those weaknesses, bolster resiliency, and lean into the strengths of some of the lessons learned from the past 10 months. And so that's going to be a part of really the main agenda item today, is an opportunity for you all to share some reflections on the challenges of the past 10 months, and what your priorities and recommendations would be for the Health Policy Commission's agenda in 2021. So we'll try to keep the bulk of the time for that discussion, and really I'm just going to open it up and ask people to chime in. Before I turn it over to our Deputy Executive Director, Colleen Elsemeyer, who's going to run through a couple of just quick updates and announcements on our work at the HPC. I also just wanted to update you all on some of the work that we are doing to help support Secretary Mary Lou Sudders, Governor Baker, and the state's COVID command center. We saw this and took this as a duty and responsibility that our agency step up and help support the state's response in any way that we can. And we have been doing that and making that a top priority. And as part of that, we have established an extension team within the Health Policy Commission that is led by Kara Vidal that is helping to support the command center by daily intaking, analyzing, and preparing graphs on hospital capacity, bed capacity, the tracking of COVID hospitalizations to really understand the capacity within primarily our hospital system is our charge, and to understand and help support hospitals when they have capacity constraints. So very proud to be able to participate and support the state in this small way. And I see many of my colleagues from other state agencies here. This has truly been a state government-wide effort. Everyone, from the GIC to the connector, and of course to the Department of Public Health and Mass Health, everyone has really stepped up in significant ways. So with that as just a brief update, I am going to turn it right over to Colleen, who is going to give a few updates. And then as I said, we're going to dive into discussion. So Colleen?
You got it, David. I just have a few slides that I will try to run through very quickly so we can get to our discussion portion, which is why we are all here. So going to start by quickly mentioning our cost trends hearing that was held 6 weeks ago. Many of you in your organizations participated in the hearing or watched it live. This was our 8th annual cost trends hearing, but it did look a little different this year, very different this year, not only fully virtual, but totally focused on highlighting the deep racial inequities and health outcomes and disparities in our healthcare system that have only been amplified by the COVID pandemic, as you all are deeply aware. Wanted to particularly highlight here on this slide and thank our keynote speaker, Dr. David Williams, who gave an extremely informative presentation on the challenges and opportunities of addressing health equity in Massachusetts and across the country and across the world. We also debuted a short spotlight film highlighting individuals across the Commonwealth who have been battling this pandemic, our frontline workers. We want to sincerely thank those of you, our advisory council members, who connected us with some of these truly inspiring individuals featured in this video, including patients, essential business owners, healthcare workers from across the state. We could not have produced this video without our advisory council. All of the materials are online on our website. The videos are on our YouTube channel. Really urge you to check out the Spotlight video if you haven't seen it. We're really, really proud of it. On the next slide, as we have discussed at previous board and advisory council meetings, as I mentioned, the advancement and promotion of equity in health and healthcare is integral to achieving the HPC's mission, which you'll see on this slide. The HPC remains committed to addressing health disparities throughout all of our work by advancing health equity and promoting social and economic justice. We so greatly appreciate the advice and expertise that many of you have shared in developing our framework and goals for health equity, and we continue to welcome that help. In fact, we've heard from a number of your organizations, as well as state agencies and others, who want to collaborate with us, and we look forward to doing this work together. We've been in touch with Dr. Clark, just looking around the Zoom, Healthcare for All, the Mass Public Health Association, MAP and Blue Cross, the League, the Mass League of Community Health Centers, the Medical Society, our hospital colleagues, of course, EHS and Mass Health, CHIA, the Connector, the GIC, the AGO, and several elected officials have also reached out. And I'm sure I'm leaving someone out, but my point is the breadth and depth of organizations really highlights the momentum and our shared priorities in this area. So I think that's really exciting, and I just wanted to highlight all of that work. The next slide shows some of the real progress we've made at the HPC since our last advisory council meeting, which was actually in July. The plan that we previewed with you all then was preliminary, and it's since been iterated and worked on and implemented, as well as reviewed and approved by our board this summer. So you'll see on this slide, we did create and publish a new dedicated web page focused on the HPC's health equity work. Just wanted to create a dedicated space to highlight our work streams where health equity is embedded, as well as our new efforts to advance equity, and also highlight some of the incredible work of others in the state in this area. So internally at the HPC as a workplace, we're focused on better educating ourselves about the impact of systemic racism and promoting DEI in our workplace in order to fully cultivate a culture of anti-racism within our agency. At the end of the summer, we brought on board a local firm. They're called Diversity at Workplace. They're absolutely fantastic. Highly recommend to support these initiatives. We've been working with them all fall and now into the winter to improve our internal business practices. And they've also facilitated our staff forums and our trainings on these issues. So continuing on this theme on the next slide, if you will, it's hard to believe that we're now about to commence the 5th term of the HPC's Advisory Council. Makes me feel old. The Advisory Council, as you all know, serves as an opportunity for open dialogue engagement among a diverse group of healthcare industry stakeholders and policy makers. And these conversations really truly inform our work. Membership, we assess it every 2 years, and the current term ends on December 31st, 2020. So just right around the corner. So the next term is going to run from January 1st, 2021 to December 31st, 2022. And existing members may be reappointed, as some of you have been in the past. However, as part of our DEI agenda, as previously mentioned, this also includes ensuring that this advisory council is representative of the diversity of identities and experiences across the Commonwealth. And that's always been our goal for this body. And we strive to continually make progress on this front with each new term. So over the next several weeks, we'll be making decisions about reappointments, as well as the appointment of new members from organizations or representing issue areas that may not currently be represented. So if you are interested in being reappointed for another 2-year term, please email me directly. In addition to any other ideas or feedback or on new perspectives that we can bring and add to the Advisory Council are also absolutely welcome as always. And then just I'm finishing up really quickly here on the next slide, our 2021 schedule. So we're still finalizing the HPC's board meeting schedule, but we have selected dates for our 2021 Advisory Council meeting. So the first meeting of the new term will be Wednesday, February 24th. And we'll have additional meetings each quarter, May, September, and December, as we normally do. All meetings will be held at 12 p.m. and will be virtual until further notice. And the full 2021 public meeting schedule will be available very soon on our website and email. And of course, you all will be the very, very first to know. And then finally, on the next 2 slides, as this is our last meeting of the year, we thought we could just take a quick moment to look back at all the reports and briefs and issues of data points that the HPC has released in 2020. I certainly won't review all of these, but our staff have been working so very, very hard to put out some extraordinary and important work this year. Obviously, all of these are available on our website. And then finally, this is my last slide. This work, the work of publications, includes brand new telemedicine program, pilot investment program evaluation report. There's a lot of interest in this area now more than ever. We ran this great program. There's a lot of lessons learned in how to deploy telemedicine for behavioral health. So please do check it out on our website if you can. And that is it for me. So I will turn it back to David Seltz. And please do let us know if you have any questions just by raising your hand. Thank you so much. David?
Great, thanks, Colleen. So 2 more quick updates here. First, in addition to the health equity work and the work supporting the command center, we have also invested heavily in trying to understand and document the impact of COVID on our healthcare system, particularly with regards to spending, utilization, the financial impact on both providers and on health plans, and also the impact on businesses and families and individuals in the form of premiums and how they experience the high costs of healthcare in Massachusetts. This has really been an interesting work stream. So much of data in healthcare and information in healthcare is lagged and time delayed, and this crisis has really required a rethinking and an acceleration of some of our data streams to try to get more timely insights into the very dynamic and rapidly changing impacts. So we have tried to mine both national data sources and local Massachusetts data sources. Shout out to our colleagues at CHIA, who have done a really incredible job of speeding up some of their reporting. And we have presented data findings at each of our board meetings this year and have created a compendium of those findings. It's available on our website. We are continuously updating that compendium because, of course, much of the information we have is very incomplete. We are still just getting a snapshot in time, and then sometimes that is still a delayed snapshot. So I think it will be really critical for us to understand the full year impact of some of these dynamics on both employment and on the financial situation of providers, and really the return of care, and how the mode of that care has changed dramatically during this COVID crisis, and a shift towards telehealth for many types of services. So I'm not going to walk through the bullet points here that are some of the latest findings here, but do want to kind of return to this when we get to the discussion, because I'm really interested and curious and welcoming of your input about what are the questions that we should be trying to examine and answer as we move into 2021, specifically with regard to impact of COVID on healthcare. I will just note one bullet here, which is the last bullet, around provider stress and burnout. We fielded 2 surveys of physicians in Massachusetts, and those results are also on our website, understanding physician perspectives and also the use of telehealth. One last update before we get to discussion, and this is really something that we're proud to announce and hope that you as advisory council members can think about helping us promote this new grant opportunity to individuals or organizations that may be interested. So I'm going to turn it over to Kelly Hall just to talk through this new grant opportunity.
Thank you so much, David. Can everybody hear and see me? So I really appreciate the opportunity to do a very brief introduction to the cost-effective coordinated care for caregivers and substance-exposed newborns, or C4SEN investment program. Next slide, please. So C4SEN is not the HPC's first foray into this space. Over the past several years, we have made meaningful investments sort of along the care continuum for pregnant mothers and their babies, most specifically our neonatal abstinence syndrome investment opportunity, which is currently being evaluated, and also our Moms Do Care initiative that we worked with our colleagues at DPA. C4SEN is a little different in that, based on feedback from our stakeholder engagement process, we identified an opportunity to maintain some significant elements of the earlier programs, namely the critical importance of integration of medical, behavioral, and social needs, but also to extend support to caregivers and substance-exposed newborns, past 6 months post-discharge, to address a period of real vulnerability. Next slide, please. So like everything that we're doing at the HPC right now, and probably in the world writ large, this program acknowledges two, parallel realities. The first is obviously COVID-19. COVID-19 has done a lot of things. What it has not done is eliminate substance use disorder or the opioid crisis. In fact, there's fair evidence to suggest that it's exacerbated it. So in introducing this program, we recognize both the increased need, but also, some of the opportunity to learn, to take advantage of some of the learnings that organizations have had through the COVID experience to accelerate and amplify the impact of their programs. Health equity is another consideration, obviously, as Colleen mentioned in her earlier remarks. We are making a continued and increased commitment at the HPC to ensuring health equity. That spirit has very much made its way into our RFP. This is the first time that we've included language in an RFP that specifically acknowledges this priority. Some of our selection criteria require provision of culturally competent care that is free of stigma and bias. We include principles for promoting racial equity that were developed by our colleagues at the DPH. And, possibly most importantly, we ask our awardees to collect and analyze data to demonstrate that they have an understanding of their target population and any related health inequities in access, particularly to medically assisted treatment for mothers and other services. Next slide, please.
Kelly, before you move on, we'd had a question from Colin.
Oh, of course.
Hi, thank you. Just two brief questions around the substance abuse issues. First, the program for the SEN program. Do you foresee peer support services playing a role in that? This seems like a critical area where that would be beneficial.
Yeah, I think it's an excellent question. I would say we have not included a specific requirement around peer support services, but I can certainly say that we have seen enough evidence of the effectiveness of peer support services in other HPC programs that I would fully expect that when applicants propose their programs, we will see that group of people represented.
Great, that's glad to hear. And then secondly, around the, in general, sort of setting opiate policy, great to see the commitment to health equity. One thing I would urge here is consideration also of the experience, like doing qualitative research and outreach to individuals with experience of substance use disorders, and particularly individuals with chronic pain. I think it's critical. We've been doing a lot of work around that intersection along with Brandeis on how to set humane opiate policies that actually reflect the needs of people with chronic pain. And there's an intersection too with racial justice, because particularly people with sickle cell anemia are a population that are often really in a double bind in this area, where, and of course, a population that is overwhelmingly Black, who are denied access to effective pain management, while also dealing with high rates of opiate addiction as a result of need for pain management, sometimes leading people who can't access legitimate pain management to turn to illegal opiates. So that's an area where I think further study and detailed qualitative research would be critical, and happy to engage further offline. I think there might be a real opportunity there.
Great, thanks for that feedback. Any other questions before I continue? Okay. Next slide. So obviously there's a lot more nuance to the program than this, but the C4SEN program structure, which will be, I should acknowledge, be managed by my colleague Wendy Nicholas, will essentially oversee a $1.2 million investment program, which we expect to apply to up to 4 awardees. It's a bit of a mixed funding model in that we began this process with a legislative appropriation, and then to increase its scope and impact, contributed some additional funds from the Distressed Hospital Trust Fund. So when we make these awards, we will be able to make awards to three organizations that qualify for the Distressed Hospital Trust Fund and one other provider organization with awards of up to $300,000 each. Our expectation is that this program will run for 24 months, including a 3-month planning period, which we included specifically to ensure that there was adequate opportunity to look at data to understand as best as possible inequities and how to ensure that the program was meeting the needs of the patients that most benefit from it. And then finally, following the period of performance, there will be a 6-month evaluation period where both the HPC does its work and awardees engage in evaluation-related activities. Next slide, please. And so here's our timeline. We issued the RFP on November 18th and have processes underway to collect and track questions. Ideally, if our timeline holds true, and we have no reason right now to believe that it won't, proposals will be due on January 22nd, and then following a review and selection process, including returning to our board for approval, we will announce awardees on April 7th. I think it is worth noting here because, obviously so much of our work is happening right now in the context of COVID, that, the program itself, meaning the engagement with patients, will not happen until the summer. So I'm sure all of us are hoping that by that time, some of the restrictions around COVID will be not quite as rigorous as they are now. So thank you so much for your time. Again, I'm happy to answer any other questions. And if there are none, I'll turn it back to David.
Great. Thank you, Kelly. And thank you through you to Wendy for the great work on this program. And thank you, Advisory Council members. And please share that information with your network if appropriate. So that is it in terms of our updates to you. And so really want to spend the remainder of our time opening this conversation. I didn't come prepared with a long list of questions here. Really wanting to have an opportunity to hear from you about your reflections, your experiences, and your insights and perspectives on the impact of COVID, both on your organizations or the people that you represent, the patients that you serve, but also really in the spirit of trying to help the Health Policy Commission develop its 2021 agenda, and what are the priority areas that you would really recommend to us that we invest our time, energy, and resources into examining further in support of both policy development, but also a greater understanding of the impact of COVID and how we move forward and heal together to build a better and a stronger healthcare system coming out of this crisis. So I think we just have a holder slide here just for reflections on 2020 and priorities for 2021. I think to get us started, I'd love to call on my friend Chris Schuster, who everyone knows is the CEO and president of Emerson Hospital, a community hospital that has been, certainly impacted by the COVID epidemic and plays a really unique role in our healthcare system. We, of course, love all of our hospitals, but we at the Health Policy Commission always have a special place in our heart for the community hospitals. And so, Chris, I was wondering if I might call on you to kick off this discussion.
I'd love to do that. Thanks, David, and good afternoon, everyone. While many things have come to the surface, and we talked already about health equity, one of the things I would love to bring to everyone's attention is children. As a mother, as a CEO in a community where many people move here to raise their families, one of the things that we've been acutely aware of is the number of children as young as 6 up through teenage the teenage years and into young adulthood, the mental health issues that have emerged, everything from young children with suicide ideations to violence, to things that we've never seen before. And it really has pointed out two things. On the outpatient side, there's no place to send these children for follow-up care if they're safe to go home with their parents. But even greater is the lack of mental health beds for children, young adults who aren't able to go home and need to be placed somewhere in the community. In our hospital alone, and I know many community hospitals and academic centers are the same, we've kept patients as many as 3 weeks in our emergency room. And emergency rooms aren't really the place that you want to be delivering this type of care. It's not appropriate. We have at Emerson adult and pediatric services available, but we don't have a pediatric locked unit. We have an adult locked unit, so we're able to care for those patients. But for the children, it's really been very difficult, and I think COVID has had an impact them on ways that we've yet to see. We're beginning to see it emerge, and I think it will be for the coming years. And so I would just like to raise everyone's awareness about that. And I hope it's a priority that we can all work together to figure out how we address this, because the children are our future. And if we don't really work on this now, we're gonna see issues 3, 5, 10, 15 years from now if we don't really start to prioritize this. So that's really my biggest thing, what I have to share today from my experience.
Thank you, Chris, and thank you for everything you and your team are doing. Just to reflect on those comments, we have seen in the data that pediatric care has been very slow to return, even as compared to as other care has come back. And I think the longer term impacts that you suggested, Chris, are really frightening and concerning, and can be unseen in many ways. We have noticed and experienced, I think, an increase in behavioral health ED boarding across the Commonwealth. I know this is a top priority for the Secretary, Secretary Mary Lou Sudders, to increase some of that bed capacity so that the placements, the appropriate care for patients is available. As you said, the emergency department is not necessarily the appropriate place for that type of care and treatment. And so I think your comments are very well taken. And, I think everyone on this Zoom call agrees with the concerns around behavioral health care in particular. I saw that Pat had raised her hand. Sorry, Colleen, maybe you can help me out here.
Dave, can you hear me, Dave?
David, your audio is going out a little bit.
Can you hear me now?
You're fine, David. Yeah.
Oh, good. Thank you. Yeah, and Christine, you're 100% right. This is David Mattiotto. For those who don't know me, I represent 47 hospitals, behavioral health, all behavioral health, either units in general hospitals or freestanding hospitals like McLean and Bournewood and so forth. And I'll just say, I've been in this position 30 years, and I'm, with no exaggeration, this is the busiest, most stressful, challenging environment our hospitals have seen. They're all full. They've been confronted with all sorts of issues from the COVID. Even before COVID, as everyone knows, there was a strained system, and now it's just really, demand has exploded. Your stories are true, and kids waiting for days and days in emergency rooms because everyone's full. And the other kind of factoid is the hospitals tell me the acuity is much more profound. So I would just encourage Health Policy Commission to look at behavioral health and what the COVID has done with exacerbating things both in terms of access and the strain on patients, the strain on kids who can't handle telemedicine necessarily all the time, or, remote schooling and so forth. So we're really seeing it, and we're doing our best, and Mass Health and DMH are really trying very hard too. And Mass Health has a number of initiatives to address this. So we're working on it every day, and you're 100% right, Christine. It's really unfortunate. Thank you.
Thanks so much, David. We have a long queue of hands up now, so I'm going to go next to Pat Kelleher.
Pat, I think you're still on mute. Sorry.
This might be a slightly nuanced view on the topic we were just talking about, which is children and post-acute services, but I'd like to see more attention in general to the whole intersection of the post-acute network and the acute care services as COVID unfolded. And that means everything from IRFs to SNFs to home health to hospice. Our friends at the Mass Hospital Association, our colleagues, have had a care continuum council, and there's been a lot of good information, best practices shared there, bottlenecks identified, bottlenecks worked through. So I think the whole post-acute world, speaking for home health specifically right now, what we're beginning to see is demand exceeding supply as home first becomes sort of a policy of many of our hospitals. And that sort of demand exceeding supply is exacerbated by our workforce having to self-isolate or quarantine when they've been exposed. We're seeing a lot more of that, and it's affecting our ability to basically serve the acute care, get the acute care patients out. So what's affecting that, and I'll just make this final sort of plea for home health, is our access to testing has been extremely limited. Only 4 home health agencies in the whole state received federal HHS Abbott tests because they did it by size and they primarily use national chains. And we've had limited access to the state tests as well. So we've been scrambling to get our workforce to the state's testing sites, and there's long waits, and it affects productivity. If you don't want to wait, then you basically have to self-quarantine for 10 to 14 days. So, the whole issue of testing of that post-acute care workforce as it affects our ability to meet demand is something I just want to raise and thank people for their attention to. And thank the Health Policy Commission for allowing me to bring that up.
Thank you, Pat. And I would offer one thought and reflection. I think the interconnectedness of our healthcare system and across the care continuum has just become so much more apparent to me in thinking about those bottlenecks, the flow of patients, pre-hospital, hospital, all of the new acronyms and SNRFs and IRFs and LTACs. I think we have just such a greater appreciation of how every part of the system impacts another part of the system. And when there are capacity constraints, how those ripple throughout the system. And I think a real lesson learned for us as a community is to think about how we have a system that really is meeting the needs of patients at every one of the different stages across that continuum, all the way back to home. So thank you, Pat. Colleen, who we got next?
So yes, I'm just going to confirm the queue here so everyone knows I've received all of their hands or private messages. Next up is Chris Carlozzi, and then we'll do Mike Caljo, John Hurst, Donna Mosh, Colin Killick, Bonnie Gilbert, Amy Rosenthal, and Dr. Strongwater. So we go quickly, don't worry. All right, so Chris, you're up first. Thank you.
Thanks, Colleen. I know this won't come as a big shock to people, but I'd really like to see a laser-like focus on health costs for small employers going into next year. There were reports they could experience nearly 8% increases in premiums going into 2021. I think we're at a point right now where we don't need to be adding additional barriers for small employers, for job growth, for the recovery effort, really. And since this group is solely focused on health needs, I'll spare you my rant on other labor costs that are going into effect next year that small employers are going to be facing. But right now, I think this is something we really need to take a good hard look at, because the recovery for Massachusetts is going to happen through small businesses. And we don't need to be doing things that will threaten the employment opportunities for workers. We want to keep people attached to the workforce on payrolls for small employers. And it just, health costs, even before this pandemic, was one of the top thing, I think, going back for a decade when we poll NFIB members. It's always at the top, the cost of healthcare. So I think we need to get back to that and just focus on lowering costs for these small employers who are going to be struggling, who are already struggling right now under all sorts of restrictions, under having fewer customers walking through the door, because it's going to have an overall effect on the state economy and the recovery effort. There's been reports out lately of 37% of businesses in the state right now are not open. Even higher in the city of Boston, I think it was somewhere like 44%. So making healthcare affordable is something that I really think we need to just have that laser-like focus on going into 2021, because small employers are already up against a lot. And, if we can do this one thing for them, it would be greatly appreciated.
Thank you, Chris. And we have definitely not lost sight of our mission here around lowering costs. That's why the Health Policy Commission was in large part established, reflecting the burden of the high cost of healthcare on businesses, small employers, families, and individuals. We share concerns around premium increases next year on top of already high healthcare costs and what that will mean for affordability for everyone. So assure you, we're not losing sight of that important aspect of our work.
Thank you.
Colleen?
Okay, up next, Mike Caljo, and then on deck is John Hurst.
Great. So I'll echo and expand upon two of the prior comments. First, with regard to Christine's comments on the explosion of need from the patient population because of the pandemic and her specific comments about children. We're definitely seeing it both anecdotally and in terms of claims that are coming in with regard to that impact. And I could not agree more in terms of focusing on what the post-pandemic medical needs of our community may look like, not just in that area, but also I could see that also including the impact on all different populations, both medical and non-medical, behavioral health as well, because there's certainly going to be medical impacts. And we are going to deal with the impact of that over time. It has a natural inflationary impact that I think is front and center for this commission to contemplate. And just from a patient need analysis, I think we have to put that in front of the agenda on the list of items, has to be really at the top. To expand on Chris's comment, I think that what we would want to make sure is in view is the long-term trend impact of spending in the marketplace, going back to kind of the root analysis of the full system view. And while I certainly agree that premiums are going to be an immediate issue for us to worry about collectively in 2021, and there's a lot of the Division of Insurance and others will be doing on the topic. I think it's important to recognize that the longer term impacts on spending, as I just mentioned, are super important for us to keep an eye on and would be consistent with the HPC's mission. Completely echo and reiterate Chris's comments. And then lastly, on equity, to go back to another topic, I think there's a particular need that the Health Policy Commission in particular could be a leader on, which is diversity and equity in policy jobs, health policy in particular in the Commonwealth. It's a particularly vexing issue. And I know that it's an ambitious agenda across the board, but to focus and to zero in on a particular topic like advancing the cause of representation and inclusion in health policy itself is a natural for the Health Policy Commission to tackle. And I just, in addition to looking at the representation on this commission, I think it's an important task that we can jointly tackle. But with the HPC's particular leadership, I think it's a great one for you to take on.
Colleen, any thoughts on that point?
Yes, I mean, absolutely. We've been thinking about that internally, both with our own hiring and open positions that we've been pursuing in COVID, and would love to extend some of our learnings and planning to the rest of the health policy sphere. And I do agree that that could be a place we could really lead on, and we'll plan to update this council at the next meeting on that. So thanks so much for that, Mike. All right, next up, John Hurst, and then on deck is Donna Mosh.
Thank you, Colleen. I won't take long. I'll just reiterate a little bit, me too, on what Chris and Mike added. Cost, David, I just hope, we all remember, the original purpose of why the HPC was created by the legislature, and let's not lose track of that. I mean, what has happened to small businesses in 2020 is incredible. I just got done tabulating our results for November, which is an incredibly important month for small businesses. With the holiday season, and it was, our members are down 12.5%, and which, believe it or not, is a very good month compared to earlier in the year. And that's after they've reinvented themselves. So many more, about half of them are now online when it was only about a quarter of them a year ago. They're doing curbside, they're doing by appointment only. They're reinventing themselves to keep the customer coming in. But then I look at the healthcare system, utilization has plummeted. The economy has really come to a halt and gone backwards. Yet we're looking at 8% premium increases next year. I think there is something incredibly wrong when our costs are that high and they continue to go up when utilization has not been there and the economy does not really warrant those kind of increases. I just, I would be remiss if we didn't, try to get refocused back on that primary function of the HPC. Thank you.
Thanks, John. And as I said, not losing sight of that at all, and we'll continue to really dive into that. And we are really thinking and interested in understanding the premium increases that were filed for January and what we, April, as you know, is a big renewal month for a lot of small businesses. And so we're keeping a very close eye on that. All right, I think, who is next, Colleen?
Donna.
Hi, thank you, Colleen and David. I wanted to comment on 2 points raised earlier. The first is your new program initiative focusing on perinatal substance use conditions and interventions, innovative interventions for mothers. I would suggest that when you develop the selection criteria for the grantees, that you consider grants that look at underlying trauma and mental health conditions that are co-occurring with the substance use condition. That will be very important to address in terms of, developing clinical stability for those mothers and strengthening their parenting capabilities. So that's the first comment. The second is, Christine raised a really important issue. And I want to underscore what David said about the increased demand. I want to applaud efforts both in the administration and in the Senate to develop funding that would enable short-term investments for the creation of new psychiatric beds, particularly for kids. But I would also comment that this ED boarding problem, which has plagued us for some time and is again aggravated by the rise in demand due to the mental health pandemic that's arisen in the context of the virus pandemic, that there are complementary solutions that also should be considered. One of which in the short term is also developing crisis stabilization beds for kids, which might not require the same level of licensure, staffing, and capital expense as inpatient beds. And the other is pediatric behavioral health urgent care, which can get a bit upstream of the event in the emergency room or be a diversion from emergency room, just as urgent care has proved a diversion on the physical health side from some emergency care. So I think we need a multi-pronged approach, and also one that both balances costs and can have the effect of getting upstream, particularly urgent care. So thank you.
Thank you, Donna. And we will certainly take your feedback into account for our grant program, and completely agree the need for a multi-pronged approach. As you said, ED boarding is not a new problem. It is such a vexing challenge that the Commonwealth has, and many other states obviously have wrestled with for a long time. And it does require kind of multiple points of intervention to try to think about getting people the care they need when they need it in the appropriate setting. So thank you for that.
Great, thanks, David. So up next, and I'm just going to go through the on-deck list here, is Colin Killick, and then Dr. Clark, Bonnie Gilbert, Amy Rosenthal, Dr. Strongwater, Rich Buckley, Lois Cornell, Carlene Pavlos, and JD. So Colin, you're up. Thanks.
Thank you so much. First, I want to enthusiastically co-sign both Pat and Donna's comments. I think that they're sorely needed. And to Donna's point, I would also add that we need a broader set of alternatives throughout the mental health care system. Our state needs more than one peer respite. That's such an effective, proven model that can reduce the strain on these facilities, that can get better outcomes for certain people. We also need to go the way of so many municipalities and states across the country in terms of alternative approaches to acute mental health crises. Sending someone better equipped to handle a crisis when it's occurring than police officers can keep someone from needing to be put into a mental health facility in the first place in quite a number of cases. And that leads me to my broader point, which is the disability community, the elder community, have been saying for decades that institutions fundamentally are outmoded. That the model of cramming together a large number of medically fragile people in a confined space for an indefinite period is not a good idea. It's not a good idea from a cost perspective. It's not a good idea from a human dignity perspective. And as we've seen during this pandemic, it's not a good idea from a safety perspective. More than 2/3 of COVID deaths have occurred in institutional settings. And there's now a coalition of more than 30 disability and elderly groups, including everywhere from organizations like us to AARP Massachusetts, called Dignity Alliance Massachusetts. We're pushing for fundamental reform of the long-term care sector in Massachusetts, an end to outmoded models that should transition towards community living as much as possible. And I would urge HPC to support those kinds of efforts.
Thanks so much, Colin. I'm going to turn it right over to Dr. Clark. Dr. Clark, thank you.
Hi, thanks so much. And I'll be brief also. I just am really excited about all the work that you're doing and pushing forward on health equity. And my recommendation would be to continue to push on the work that you've done around social determinants of health. It's just, as I sort of think about COVID, and I think John Hurst also mentioned, how devastating this has been on small business, and definitely small businesses that are run by Black people, Indigenous people, people of color, have been devastated. As I think about even the pop-up tents and the sort of community COVID testing sites that we did, where we offered screening for food insecurity as a social determinant, there were days at some of the sites where 80% of people who showed up were actually coming for the food, as opposed to or were screening positive and were coming for the food. And there were people who came back. They'd already been tested, but they were hungry and they were coming for the food. And the kind of work that HPC and that you have done, or for example, with Mass Up, really prioritizing food insecurity, economic mobility, and interesting partnerships, novel partnerships has been, I think, a real North Star, has allowed Mass General Hospital and others to do really innovative work with community development corporations and incorporating that upstream focus into healthcare. And so really excited about the possibility of you continuing to push on social determinants, structural determinants, and having that as a part of the incentives for the work that happens in the future in 2021.
Thank you so much, Dr. Clark. Absolutely agree on all of that. All right, Bonnie Gilbert.
Hi, everyone. So first of all, I do want to say how much I appreciate Christine's comments and some others about teenage mental health issues. We hear the stories all the time at GBIO about the significant increase in problems. My own family has experienced it. So we are, I want to just second all of those comments made. I also just want to say, in terms of the equity issues, from our perspective, affordability and equity really go hand in hand. If the costs are so high for other services, it's much harder to provide everything that needs to be provided on an equity side. So we see them as, two sides of the same coin. On a more specific issue, when we talk so much about affordability and the increase in costs, I just want to get a little granular for a second. GBIO was a supporter of seeing telehealth being covered, in the emergency bills, the emergency acts, especially around mental health, even though I can vouch for it not being the cure-all for all mental health issues, but it definitely has been a lifesaver for many, many people in our population. But telehealth also, I think, does bring some other potential cost issues that I think that we need to just kind of be aware of. For instance, and I'm just going to give you a couple of stories. For myself, my daughter saw a GI specialist at Children's. It was August. No reason really for it to be a telehealth visit because it was August and caseloads were down on COVID. She was having symptoms, and yet it was a GI specialist visit where she pressed on her own belly, and we got a $1,000 bill that got reduced to $900. It was a 15-minute call, plus a $100 facility fee charge. Okay, I'm sure if we were not on mute, we would hear a lot of guffaws on that. Another person I know was told by their doctor when they called on the weekend just to check on, you know how we all call our doctors sometimes for just a quick question. The doctor called him back and he was told, first of all, I need to tell you right away, and this was also both, one of our major healthcare providers systems, I need to tell you right away that this is going to be charged as a telehealth visit. So this really goes to, I think we've seen this time and time again, where we've tried to take actions that will help the residents of Massachusetts try to provide more services, and yet they've been turned into monetizing opportunities that have driven up our costs. So I just want to put that all out there as something that we need to be keeping in mind with all of these changes in services. Thanks.
Thank you, Bonnie. And you can expect that we will be taking a good, close view on telehealth and understanding how that has worked and not worked. There are, as you said, both affordability and equity issues around telehealth as well. And I had heard about this concept of a telehealth facility fee for the first time last week, and my jaw dropped. So we will be looking into that dynamic as well. All right, Colleen, who do we have next?
Amy Rosenthal's up next.
Hi, everyone. There's so many things I want to say I agree with. I'm going to try to keep it fast. To building off of what Bonnie was just saying around affordability, and also picking up on what Chris and John said earlier as it related to small business. I mean, I just can't stress enough. It was an issue before COVID that consumer affordability issues were a huge problem. And now families are just really struggling in so many ways. And so I think it's a question about how we make sure we're continuing to be reformers and thinking about what we can be doing statewide to address costs for consumers and underlying costs and how that feeds into the problem. So I'll say that for sure. I also want to touch on issues around both health equity and really dealing with structural racism and really kind of taking it to that step and really thinking about it. What Dr. Clark raised around social determinants of health, I can't emphasize enough how important that is. And Healthcare for All has been trying to spend a lot of time recently thinking about our role in working on social determinants of health. And I think that every organization in the healthcare space really has an opportunity to be doing some work in this area because it does obviously feed into how people's health is overall. Again, I also want to second all this discussion, particularly around pediatric behavioral health and thinking about it as an integrated part of the healthcare system. So I want to touch on that. But the one other thing that hasn't come up yet that I do just want to flag that we've been hearing on our helpline throughout the pandemic is around issues for our immigrant communities. And specifically that there has been so much on the federal level over the past, many years, several years, which hopefully will change. But things like public charge have really created this chilling effect for people who are afraid to come into the healthcare system and to get coverage. And we spent a lot of time, unfortunately, a year ago, with people disenrolling from health insurance coverage because they were worried about public charge, only to have them call back in March, April, May to help them re-enroll in coverage because they were now scared about COVID. And so I think that there's a lot that we need to be doing in our own communities to make sure that we're creating a safe space for people to be getting the care that they need, because obviously it impacts all of us. Thanks.
Sorry, Colleen,
I was on mute. I've been doing this for 8 months. Sorry. Sorry, Dr. Strongwater, you're up next.
Yeah, great conversation. I compliment the work that HPC has been doing this past year. I'm going to put 3 things on the table. One is we practice how we are paid. So perhaps now is the right time to move towards global budgets at a minimum for primary care docs. The second is the impact of delayed care. That has a lot of issues that will drive costs going forward. And then last, which Dr. Wagner also mentioned, is the workforce. And it's not only the workforce as impacted by COVID, but generally the availability of support to keep the workforce working, which really is childcare. And so if you have the bandwidth to take on yet more, I would add those 3. Thank you.
Appreciate that. Thank you so much, Dr. Strongwater. Okay, Lois Cornell from the Medical Society.
Thanks so much. I'm not going to echo everyone's comments, but I'll just add to a few. Dr. Clark's comments about really looking at health equity and social determinants, I think is a really important one. And I'd urge the HPC to be thinking about the cost and value places that you go and the areas that you've been focusing on to really put a lens on it. Of looking at the issues of racial equity in the delivery of care. And that I think we all recognize takes a number of different levels and areas of focus and commitment. But actually, as I was looking at the materials as you went through it and earlier, Colleen, you're on that now. And I think this would be a really good opportunity to do that. I'd also just want to suggest that as we're talking about and Christine, thanks for raising the issues about children and pediatrics and behavioral health. There's an opportunity to be looking at broadening the primary care model and really how there is a need, I think, for trying to look at integration of that primary care and behavioral health and trying to keep the kids out of inpatient settings. And that inpatient setting need is very, very real. But to be thinking about ways that we can also be revisiting that primary care reform to be able to do that. So I'll leave it at those 2, but thanks for the opportunity to speak.
Thank you so much. Oh, sorry, David.
I just wanted to echo thank you, and also echo Colleen's comments earlier. A lot of you have mentioned the priority of equity in our work, and really just want to have another call to say let's work together. There's such great momentum on this issue, but we have to make sure that that momentum translates to action and meaningful action. And we don't. It takes a community, and all of our organizations together can really make a difference. And so we stand ready to be partners, supporters, cheerleaders in any way that we can.
Great, thanks, David. Okay, switching now to Rich Buckley, and then we have Carlene and JD.
Great, thank you, Colleen. It's the old saying about everything has been said, but not everyone has said it yet. But many of the same themes. David, we're part of a partnership for health system resiliency and sustainability. It's being led by the London School of Economics, World Economic Forum, making recommendations to the G7 next summer about those very things, health system resiliency post kind of COVID world. I suspect looking at some of the early policy proposals, they're not surprising. They're many of the fundamentals that we talk about all the time. It's prevention, screening, early detection, and probably locking in telehealth with some of the issues that have been discussed here in mind. I mean, we've seen in cancer care, diagnoses are down over 40% this year. And that's not good news. And the correlation between early detection of cancer and outcomes are well noted, not just in cancer, but in other therapeutic areas as well. And of course, those dynamics are only more amplified in communities of need. And so, thinking about policies next year that have people returning to their care, ensuring continuity of care, ensuring people are also taking those preventative measures, early diagnosis, screenings are going to be really critical, or else bad outcomes are just going to be further amplified. Thanks.
Thank you, Rich, and do want to take the opportunity to recognize your organization's international leadership on the development of a safe and effective vaccine. And I see Bob Coughlin also on my screen here, and many other local companies that are leading the charge here. Just stunning innovations in the science that hold so much promise even beyond COVID moving forward. So thank you, and thank you for what your organization does.
Carlene, you're up next.
Thanks so much, Colleen. And David, thank you for those comments.
Oh, Carlene, we just lost you.
Is that better? Okay. David, thank you for the comments about really wanting to be a good partner around health equity, because I think that that's some of the most crucial work that you're doing right now, and have so appreciated how seriously you, Colleen, and the entire staff have really been taking it. When Dr. Clark was talking earlier about the social determinants of health, I just wish I could have made a lot of noise and cheerleading about it. I think that the investments that you've made in Mass Up, and really focusing not just on the health needs that are created by the social determinants, but actually on shifting the social determinants, is crucial work for the Health Policy Commission, precisely so that it can meet its mandate of lowering healthcare costs. I mean, we know that it is in communities that health is generated, and the reasons we see such poor health in some communities is because of social determinants. So what the health system can do to invest in that is really critical, and throwing the weight and credibility of the healthcare system and the Health Policy Commission in that regard, really, I think it's just critical to sort of where we need to go. I also want to raise something that hasn't been talked about yet, which is data. We do not have acceptable data on race and ethnicity in this state. It is wholly unacceptable. The race and ethnicity data that has been reported during the COVID crisis is shockingly incomplete. In other variables, disability, occupation, a whole list of other variables where we know there are inequities, it is even worse. It's unacceptable. And again, if we are really to be credible in our claims for addressing health inequities, we have to have data that helps us understand what those inequities are and helps us formulate policies to address them. We can't do it without data. HPC needs to be one of the voices calling for better data. And finally, policy. I really appreciated the call for diversifying the health policy workforce, but it is more than that. It's also really having a policy and an analytical framework for looking at the policies that we're promoting that says, will they promote equity? And that's one of the touchstones. It's not equity coming after the policy. Like, let's see if that policy, gets us lower costs, and then we look at the question of whether it will also bring about equity. If that's how we do this, we will keep repeating the issues that are embedded in our system. We need what we call at MPHA, a health equity policy framework that is used in every decision about whether that is the right policy to be promoting and advancing. And without that, I just think we're going to continue reinventing other ways to talk about equity without actually making any progress.
Thank you, Carlene. And a couple reactions. First of all, thank you for the words of gratitude and appreciation. You have, and many others, Dr. Clark included, have really pushed us to be bold on talking about these issues. And I really appreciate you also making that clear connection, because there is, between healthcare costs, equity, and social determinants of health. There is a linkage here that that we see, that is why we've made it integral to our mission to reduce healthcare costs. Equity is part of that. It is integral to that. So thank you for that. And on the data point, just wanted to say we agree, and we have already this year engaged with CHIA on really going through the data sets that we both control as two state agencies, and really re-examining the data that we're collecting.
Thanks, David. Okay, JD Chesloff.
Great, thanks, Colleen. And thanks everyone for really insightful, thoughtful comments. It's been wonderful listening. Just a couple of quick things. One, just to make it unanimous, we at the roundtable also very much support your focus on equity. Something we're struggling with and working on at the roundtable, and just finding that it takes commitment, it takes real intentionality, it takes a sustained effort, and it sounds like you are committed to that, and I'm grateful for that. So thank you. Second, I did just want to amplify what John Hurst and Chris Carlozzi and others from the business community said about cost. The roundtable, for those who don't know, are generally larger employers that have a different set of issues around healthcare, but there really are no larger employers without small employers. I mean, it's one ecosystem, and the cost implications are they're pretty acute right now. So appreciate the focus on that. Just want to amplify what John and Chris said. And then just one final comment that I don't think I've heard too much about, but with roundtable members, the remote work phenomenon has had a real impact on how the employer-employer relationship, and how employers are supporting their employees, right? So we've done a little survey work, which we're updating now, but prior to the pandemic, about 18% of employees were working from home. Now, again, amongst roundtable members, it's about 87%. And the expectation post-COVID is that it will remain almost 50%, is what we're hearing, 45 to 50%. So when you think about the relationship between the employer and the employee, and some of those supports, particularly around benefits, a T-pass or a parking spot doesn't really have as much value anymore if you're not commuting, but perhaps subsidies for childcare do. But one of the things we're hearing, more relevant to this conversation, is the way employers are supporting employees is through increased flexibility, extended leave, but really significantly more supports around mental health for their employees. people are feeling isolated, they're feeling anxious, they're working incredible hours. And there's a real intentionality again around supporting employees' mental health and what the employer role is in that. And a lot of that is going to start, I think, happening through benefits. So it's just something to keep in mind as remote work takes hold and probably is here to stay to some extent, that you may see much more focus on the mental health implications of that.
Thanks, JD. That's really interesting, and we have, as you know, been thinking in the past about the role employers have and the voice of employers on healthcare issues for their employees, and do see that it will change and evolve, as you said, in the next year. So let's keep in touch.
Great. Steve Walsh from the Hospital Association.
Thanks, Colleen, and thanks for the great discussion in the forum, David. And in this spirit of Thanksgiving, thanks really to all of you who have partnered with our health and hospital system members over the past 10 months to do really the unthinkable. We're talking a little bit about priorities for next year, which is critical. We got to be always thinking about how we can improve, how we get better to our colleagues and friends in the business community, how we can lower costs, fulfill the mission of the Health Policy Commission. But we do have some present day challenges that I wouldn't want the day to go by without us thinking about. We have lost now more than 10,000 people in Massachusetts since COVID started. There's a family behind each of those. And in many cases, there's a caregiver that spent their last moments with those individuals. And we are only at intermission. The play isn't over yet. We're about to enter Act 2. It's going to be longer, more difficult, and more tedious to meet than Act 1. The fatigue that our health system providers are feeling, that our frontline workers are feeling, is real. But for the $2 billion in federal aid, thanks to our congressional delegation, our hospitals would be in a state of somewhat destitute shape at this particular moment. They are not. To this point, it's been about a break-even proposition, but they will all come out of this weaker than they went into it. And so maybe when we get back together in February, we kind of have to talk about the infrastructure, how we're going to be able to meet the needs of our patients in our communities, how we're going to be able to meet the needs of the real priorities we have around lowering costs and fulfilling serious, significant concerns around health equity in urban centers and underrepresented communities. Those are all critically important, but today we're looking at capacity challenges in some hospitals in the Commonwealth that will have challenges for beds in the coming days or weeks. By the end of the year, we might see that replicate in all hospitals in the Commonwealth. There are some significant challenges. We're going to need all of your best efforts moving forward. I heard the concerns about telemedicine. I appreciate them. There are some concerns. We'll work out the kinks, but it has been a game changer. One of the only reasons we've been able to see patients over the last 10 months is because of telemedicine. There's always a story about some of the challenges, and appreciate the GIC not having copays for telehealth visits for the foreseeable future while we get through COVID. And I know Blue Cross has done that. I know others will follow. Appreciate our partners in the payer community standing with us. Behavioral health is a serious concern. The mental health of our caregivers, our frontline workers. This is not a simple worker wellness. This is serious challenges with more than 40% of people experiencing mental challenges because of dealing with COVID on a regular basis. And I just point this out because we have hope, right? The cavalry is coming and we think that's the vaccine, but we're going to be chasing a surge with a vaccine. It's not a great way that we should be preparing for the future. Our caregivers and our hospital health system spent the last few months doing several things, getting as much personal protection equipment as they can, figuring out how to increase capacity, figuring out how to treat our patients better so they're not as sick as they once were, figuring out how to take a regional approach through the leadership of Secretary Sutters and you, David, to make sure that Our Commonwealth is broken up into regions that could load balance and share resources and work together to make sure they met the needs of the patients. And then thinking about all the other patients. As Rich said earlier, there are 50% of cancer diagnoses that didn't happen in March and April. There are 30% of heart disease that wasn't diagnosed in March and April. There are 25% of stroke symptoms that wasn't diagnosed in March and April. There are 20% of pediatric visits that didn't happen. When those patients came back to the hospitals, they were sicker than they were before. They jumped right over a medical surge and they went into the ICU. So we have serious, serious challenges. We're going to meet these challenges together as we always have. Our health system in Massachusetts is better than anywhere in the world. The leadership of our governor, our secretary of the Health Policy Commission has been second to none. The legislature has responded when asked, and so have our caregivers, and so have our hospitals, so have our healthcare providers, and frankly, so have all of you. So our system is strong, but I wanted to offer a little bit of a cautionary tale. We're not out of the woods yet, and because we have been dealing with this so long, we all want to look to a brighter day and think about how we can learn from this and create best practices for the future. But as of now, I want to make sure that we're not bringing a bucket of water to a forest fire. And that's where we are now. And our caregivers in our hospitals are going to need continued help and support for the next few months. And so thank you, David, Colleen, for the incredible work of the Health Policy Commission. Thanks to those on the call for the incredible work. It has been truly remarkable and a level and spirit of collaboration, the likes of which I have never seen. I know, David, you and Colleen and I have talked about it. You have never seen it. It has been truly extraordinary. But again, we've got a whole second act to go. And I know we're up for the challenge, but I don't want us to lose sight of that. Thank you, David.
Thank you, Steve, so much, and thank you for your leadership during this crisis. Laura Pellegrini, you're up next.
Steve, I want to echo some of your comments. We lost a loved one to COVID, so I saw firsthand from afar on FaceTime the dedication of our frontline workers. And it's something I wouldn't ask anyone to experience when you can't be with a loved one when they're gasping their last breath. But our frontline care workers were there, and they're under enormous pressure. It has to be very, very hard to go to work every day and to deal with this. There have been so many comments today. Again, I don't want to, reiterate what we've already heard, but we've heard a lot about premiums. Premiums reflect the underlying cost of care. The work that the HPC has done to shine a bright light on cost is so important. And as you've said, David, that work will continue. So it is important that we continue to educate ourselves and we look for ways to try to improve and collaborate and work together. Relative to health equity, MAP will be putting out an announcement. We should have timed this a little bit better, but at 2 o'clock today on a project that we'll be working on. HPC will be an advisor on the project, so we're very excited about it. And so it's a piece of the puzzle as we deal with trying to address health equity. So look forward to that announcement after 2 o'clock today. So David, to you and Colleen, thank you for all of your work, and to everyone here who have been so absorbed in this pandemic and this crisis. Let's continue to work together. This is a special state. So thank you.
Thanks so much, Laura. Appreciate that. All right, Matt Vino, the new head of the Group Insurance Commission. Welcome.
Thank you, Colleen. Thank you, David, for your continued work, and thank you, everybody, for participating in this. It's good to join back into some of these discussions after a little brief hiatus. Like a lot of folks who have spoken before me, we're focusing on a lot of the same things. Our primary task, of course, is to make sure that we're providing easy access for our members to all the services that they need, both related to COVID, but also all the underlying health conditions that people need to continue to address. Certainly the behavioral health need, I think we've seen utilization really spike, which I think is both a good thing and a bad thing, of course, right? Bad that people need those services, but good that they are accessing those services, again, largely through the introduction of telemedicine. We're doing our part there. I think we've heard some encouraging news, kind of fruition of the work of my predecessors here to work with carriers to expand their behavioral health networks. So we're certainly the system capability around behavioral health continues to vex us all. And I think we all need to do our part there. That's certainly high on my agenda as I step into this role. And I do want to applaud David and Colleen and the HPC for taking on health equity. That is also certainly a high priority of mine stepping into this role. We will figure out what we can add to the collaborative effort, working with you all and other state agencies and folks in the private sector to address those issues. And David, you said it right, which is meeting that need is essential to having a healthcare system that works for everybody. So it is part and parcel of your work. It's not I don't see it as a distraction of your primary mission. I will say the challenge will always be, as HPC takes on other issues, is to find a way to stay focused on your core mission, right? And so as you get into some of these other important areas, I would, I think translating a broad area into specific, achievable, concrete measures, I think will be important for you to be able to continue to do all that you do. And I will say, just to echo the many concerns of others around healthcare costs and the rising burden on those that pay premium, including, in our case, the taxpayer. I really worry that we have a sort of a convergence of a few, I don't know, colliding challenges, not to use too many analogies here, but we will most certainly have a substantial and persistent impact of the COVID pandemic on disease incidence. We know what some of those are. They will be the result of deferred, really important and essential care. I think some of the work that David Auerbach presented at your last meeting really raised some concerns in that area about necessary care that's being deferred. That will have an impact. I think we just don't know what the disease progression will be and what the long-term impacts of the virus and recovery from the virus will be. Not to mention the persistent long-term behavioral health impacts on residents of the Commonwealth. So we'll have that sort of added burden of the COVID impact on the population that we'll have to deal with. And even before COVID, we, as I'm sure my colleagues at the DOI, were seeing some really worrying underlying trends in healthcare costs, and those are going to return. There's no question in my mind. We certainly see, not to sound like a broken record here in this audience, but provider unit prices continue to be a primary driver of our trend. The data certainly shows that. It's not the only one. Specialty drugs and drugs administered in hospital on the medical benefit, really some eye-popping numbers there. So those are all going to come back as well. And then the other colliding trend here, that again worries me, is what Steve Walsh mentioned about the pressure, and others have mentioned about just the stress and pressure that this whole experience has placed on our provider delivery system. And we're going to see an urgency and a growing urgency and need to address cost impacts at a time when hospitals are really kind of getting back on their feet. So I think we have some real challenges ahead in navigating those cross currents.
Thank you, Matt. And challenges today, challenges ahead on a whole variety of issues that you have all raised with us today. And to one of your points, Matt, I think one of the principles that Colleen and I have for how the Health Policy Commission can play a role on all of these different issues is to seek out partnerships, to seek out areas of collaboration between, where we can support other state agencies, we can support other organizations within the Commonwealth, and through that have a multiplier effect on impact. And so definitely see this as community action of government and all of you. So it really is an honor to work with all of you and to have you be a part of the Health Policy Commission's Advisory Council. This was a really great conversation today. As Steve said, we're in a really tough situation right now. So be well, be healthy, take care of yourselves and your loved ones. And thank you to our caregivers and essential workers. Have a healthy holiday season, and we look forward to seeing you in 2021.